all, let me just say thank you. I know that getting an appointment to see you is hard for you. So thank you for the time that you're making to make a conversation with me.
Oh, 100%. I like seeing you.
Dr. Tobias, during the previous conversations that you and I have had a chance to have, as well as my partner, you have mentioned that your patient practice is much younger, and that based on Biktarvy's new indication, you see no need to switch patients on Biktarvy with one or more comorbidity to Dovato. Is that still the case?
Yeah, I mean, it's still the case. When a lot of my patients don't have comorbidities, because I see a younger population, but I feel safer with the 3-drug regimen, not fully bought in on the 2 drugs that I've been burned in the past.
And I understand that. I think that in the past there were many studies trying to pair 2 drugs because there's a benefit of treating patients with less. HIV is the only disease state that we keep treating patients with more medications that probably they need. The important part was getting the 2 appropriate medications with the same PK data that would allow to keep levels consistently and one not, tapering off or the side effects being awful. And that's where Dovato comes from. Okay. When I've asked you to switch your appropriate patients to Dovato, what have you heard me say? I just need to check in with that.
Well, it's been a month, and I see a lot of patients and other reps. But what I've heard in the past is just if I have an older patient, they have multiple comorbidities. Maybe they're on older regimens like Triumec or Genvoya. Look to switch those patients over. I've kind of pushed back on the Biktarvy patients, so I know you've mentioned that patient numerous times, but that's what I've heard is try to switch those patients over.
Tell me more about the holding off of switching Biktarvy patients.
I just don't want to break the trust with my patients. They're on Biktarvy, they're doing well, they're suppressed, and if it's not broken, I'm not gonna fix it. Plus, I'm super busy. It's tough. I mean, they're doing well. I'm gonna just keep refilling because I just don't. There's a little bit of that risk of maybe it might blow the instant class if I switch them over to something like Dovato and resistance develops.
So what I'm hearing you say then is that you're concerned about resistance showing its ugly head if you switch your patients?
Yeah, I mean, I hear it all the time from the Gilead rep.
Okay, well, this is the Dovato rep. Let's just leave Gilead outside in the parking lot, okay? Dovato is much, I think Dovato will open the door to treating your patients ahead for a longer period of time. You have younger patients. Some of your younger patients, depending if they're Gen Xers, millennials, it all depends. Some are more concerned about holistically how the impact of all these medications might have in the longer term, okay? And if you look, for example, someone, let's just say Angie, she's 49 years of age. She's not that invested in her healthcare, but she's counting on you to guide them and hold their hand moving forward with their treatment decisions. And moreover, someone like Anne, when you look at the entire breadth of data that Dovato has had, the drug development program from naive trials to stably suppressed trials, have shown the clinical benefit that someone like Anne would benefit from being switched from Biktarvy to Dovato. In addition to that, head-to-head trials in pharma are very rare to find. And here you have Diane and Pasolovlin specifically for that question around resistance that you might have and that concern. Let me take you briefly to Diane, that we've talked a couple of times about it. Do you remember anything about Diane?
Yeah, so I do remember a little bit. It was head-to-head, and you switched a bunch of patients from Biktarvy over to Dovato, and it held up pretty well.
Correct. So you remember that the efficacy was there, right?
Yes.
So yes, the efficacy in diet of those patients, 2/3 were switched to Dovato, 1/3 remain on Biktarvy. But more importantly, what do you remember about the resistance? Because these patients, 60% of them had unknown genotypic history. So that your newer generation that moved, relocated, you might not have information on their genotypes, right? And you don't want that ugly head of NY40 showing up. What do you remember of those patients?
I kind of remember, it just felt like you guys got a little lucky and there was not too much resistance.
Well, what you can see here, and this is just a reminder, double the patients on the Dovato arm, you would see double whatever was going to show up, right? In each arm, one patient had confirmed virologic withdrawal. These were measured by 2 back-to-back viral loads greater than 50. That's your archive genotypes that seldom are done. And I think the surprise comes from the Biktarvy arm, and look what happened there. So does this data, as well as real-world data that has over 50,000 patients, drug development program, does this put to rest now that there's no problems with Dovato's high barrier to resistance?
It sure gets me a little bit closer to thinking that Dovato could hold up in more patients than I'm prescribing right now.
You're closer, what's missing? Because I need to stop this conversation around resistance today, because Dovato has a high barrier to resistance.
Because if I didn't know their history, I mean, I think you mentioned something, but if I didn't know their history, I get patients from all over the city, and I have no idea what's going on.
60% of the patients had a known genotypic history. That is a lot.
That's impressive.
Okay, so with that now, can we put this aside?
I don't think I have another choice.
I'm going to ask you respectfully then, what is the third agent adding? What is the third loop adding in terms of efficacy and high barrier to resistance?
Maybe a little safety blanket for me, but clinically and with the evidence that I'm seeing, it doesn't seem like it's adding anything. I know there's still going to be patients that I need to write a third agent for, so.
Well, yes, and that's probably your patients that have hepatitis B and have a documented M184B. I don't want those patients. Those patients need to be niched on Biktarvy. I want your other, 90% of your patients? Those patients need to hear from you a recommendation to Dovato. And they're expecting you to have that recommendation because in the paired survey of patient-reported experiences with Dovato of 474 patients, 74% of the patients said that they expect the doctor to drive that conversation. And 79%, those younger guys and gals that don't want to have more meds, say that they would be happier with less medication. And you don't have to worry about patient satisfactions and all that because out of a maximum score of 60, 57% of the patients said that they were really, 57, the score was 57, they were very happy with the switch to Dovato. And moreover, because it's not stopping there, twice the patients were happy from the switch to their previous regimen. And remember, most of these patients were already on a modern regimen like Triameg or Biktarvy. 46% of those were there. Can you give them, starting today, the recommendation of walking with a sample and say, hey, I want to optimize your treatment today?
Well, I want happy patients, right? And right, I think I could have a conversation with them for sure.
Not a conversation. I want you to start recommending the doctor.